Relax with the Saturday Night Cafe. Tomorrow morning at 7:30, it's Religion on the Line with Rabbi Potasnik and Deacon McCormick. At 1 p.m., join legendary Bob Grant as he talks the issues and takes your calls. Your New York weekend on 77 WABC, where New York comes to talk. 77 WABC.
Welcome, everybody. It's the Radiosurgery Show with Dr. Gil Lederman, MD, New York's only Harvard-trained, triple board-certified radiation oncologist who brings you the latest cancer treatment news, interviewing world-renowned cancer experts, delving into special cases, and, of course, answering your questions. I'm Rob Redstone, broadcasting from the WABC studios in the heart of New York City. And now, please welcome Dr. Lederman.
Good morning. I'm here with Rob Spencer, who's my co-pilot today. How are you today?
I'm great, Doctor. How are you?
Fine, thank you. We're broadcasting live at WABC in the middle of Manhattan. And I've been reminded by Aaron, who's going to take your calls, that our number is 1-800-848-WABC or 1-800-848-9222. So feel free to call, speak to Aaron. If you want to leave just your name and address, we'll send you a free booklet and a DVD about our work, or stay on the line and we'll answer your questions or listen to your comments. So again, the live hotline is 1-800-848-WABC, which is 1-800-848-9222. Coop is running this show. Technically, I want to thank him because he's so fantastic. How was your week, Rob?
It was really good, Doctor.
So we're here to talk about news, cancer news, health news. We're here to talk about interesting patients. We're here to answer your questions. As I said, we're broadcasting live. And we also have guests who are experts in the field of cancer and cancer-related fields like radiology to comment on new studies, bring their information to us, and to answer your questions as well. So I thought I'd start out with a new study that was just published from Stanford that looked at radiosurgery for lung cancer. Rob, do you know what radiosurgery is?
I think it involves radio beams or something like that.
Right. Radiosurgery, it's a misnomer, really, because it's talking about surgery. And it stemmed from doctors in Sweden in the 1950s that tried to avoid surgery by using very focused, very intense radiation beams to hit abnormalities. It could be a blood vessel abnormality in the brain called arteriovenous malformation, which is prone to bleed and even cause death. Could be brain tumors. And now it could be cancers in the body. So there are lots of patients out there who can't have surgery or don't really want to have surgery. And we're going to talk about some of those this morning. Radiosurgery is a non-invasive technique. We were actually the first in the Western Hemisphere to perform stereotactic body radiosurgery.
Wow.
That started in 1997, and we've treated about 20,000 patients. So it's a long experience, and we're very proud of our experience. First study that I want to speak about today is actually from Stanford, and they also have now started in believing that stereotactic radiation works, which is not news for us because we treated about 20,000 patients. We followed them, and overall, of all the patients we followed, the success, and success means where you treat. Can you stop, shrink, or make that cancer go away? It's about 90%.
Wow.
So that's true for small tumors or big tumors. So anyway, they wrote an interesting paper because they're new at it, and they were looking at early-stage lung cancer and said that stereotactic ablative radiotherapy for early-stage lung cancer is a highly promising new modality, and they had good outcomes. One of the doctors there was Billy Liu, a thoracic oncologist at Stanford, and they investigated high-risk patients who were borderline candidates because of, guess what, poor pulmonary function. Well, why do people with lung cancer have poor pulmonary function? Take a guess.
I'm guessing the lung tissue is compromised.
Yeah, many are smokers. Probably 98% are smokers, so the smoking causes emphysema in many. It diminishes the lung capacity, And if patients don't have good lung capacity, then surgery is fraught with great danger. Maybe even the doctors would be unable to get the patient out of the hospital because they may not get out of a respirator. So non-invasive treatment, no cutting, no bleeding, is particularly appealing. So he looked at 54 patients with early-stage non-small cell lung cancer. Most lung cancers are divided up into two main types, small cell and non-small cell. And non-small cell includes all the others, adenocarcinoma, squamous, large cell, mixed cell, etc. And then evaluated patients by PET scan and mainly by PET scan, CT scan. And they had 45 patients who were medically inoperable, and they had 9 patients who refused surgery. They had a thoracic surgeon who evaluated all the patients who were thought to be inoperable. And
what does it mean to be medically inoperable?
Medically inoperable means that, let's say you can have a small nodule, a half-inch or a centimeter nodule in your lung. So theoretically, the surgeon would be rushing in to cut that out.
Right.
But what happens if the patient has such poor pulmonary function that if you cut out a little bit of the lung, that's going to throw the patient into respiratory distress?
Okay.
Or what happens if their cardiac function is so limited, so impaired, that you can't get them through the operation?
Right, it's too dangerous.
Or what happens if you have multiple medical problems, kidney failure, and you can't go through anesthesia? Surgery is often very troubling for patients, and not everyone can get through it. I know there's some patients who have surgery one day and walk out the next day. My daughter had an appendectomy, and the next day was jumping around in bed, rushing to get home. But not everyone's that lucky, healthy, fortunate. And so some people are just not medically able to, and some people are afraid, justifiably afraid of surgery.
Right.
So they followed up these patients. They followed up for 13.2 months, and the control rate, the ability to control that cancer that they treated was 100%.
Wow, that's unbelievable.
So that was good. Progression-free survival was 83%. So 100% of their cases where they aimed the beam, the cancer stopped. They then looked at what about did the cancer travel somewhere else? That's what progression-free survival means.
Yeah.
And that was in the 80% range, 83.
That's outstanding.
And the overall survival was 87%. And the cancer-specific survival was 94%. So overall survival means, okay, you're alive, but maybe you died. Those other patients, 16%, had heart attack or stroke or hit by a car.
Right.
So then you do cancer-specific survival, and it was 94%. So that's what percent of patients died from the cancer was 6%. So 94% of the patients were alive a year later, and all the patients where the cancer was treated were controlled.
So those are great results.
So it's good results. That's very typical of what we see. And we started the program of radiosurgery. We were the first in America to start radiosurgery. We started in 1997, so we're about 16 and a half years out. And the ability to control cancers is much greater with radiosurgery. Standard radiation, because it gives a lower dose and a larger field, can hurt the healthy tissues, and also a lower dose per fraction. A fraction is how much radiation is given per treatment, is not as biologically effective. So there's more biologic effectiveness if you give a larger fraction and then fewer treatments.
Okay.
And that's what we do. So we try to focus on the cancer, give a large dose, but few treatments. So it's more convenient for the patient. It's more effective for the patient. There's less side effects because you're not giving radiation to a lot of healthy tissues. Like, what's in the chest? Well, there's a lung. And again, you're talking about people often with emphysema or lung disease, so you don't want to radiate healthy tissue because that will cause harm to their healthy lung. You can radiate the heart, which actually I wrote a paper 25 years ago when I was at Harvard, and it was the first paper that looked at cardiac toxicity from radiation. And in those days, low-dose radiation to the heart was thought to be innocuous. And I started doing an analysis of men with testicular cancer and following them up years later, and we actually found